open discussion. One of the things that I'd invite any of you to comment on, because all three of you have touched on it, is the role of context and how we might measure context. And obviously in the ARISE study, Sandy, you controlled for a number of variables in your analysis, but there's a whole stack more going on in our intensive care units that we don't count and we can't control. And maybe that's the reason that we see some studies produce positive results and some that don't. Would any or all of you like to comment on that in the setting of sepsis?
One of the things that I think was really interesting when you compare our results to those of process is two things. Firstly, if you look at the resuscitation algorithm, we both used the same resuscitation algorithm, and yet we, in our study, used way more vasopressors than they did in process, and process used way more fluid. And yet we were both following exactly the same algorithm. We also had the same inclusion and exclusion criteria, and yet 95% of our patients came from home, and only 75% of patients in the process trial came from home. And we had much more patients excluded because of limitation of therapy. So how we, even if you have identical inclusion, exclusion criteria and identical intervention, how we as clinicians apply or interpret that is completely different, and that does depend on the context, the organisational structure, our own philosophies and beliefs, and yeah, it's completely different.
Yeah, no, I totally agree with Sandy. I think one of, apart from just having a good standard definition, even as you say, it was beautifully demonstrated just how variable the practice will be. PROMISE will probably be reported early next year, probably at Brussels in March. And I'll be fascinated to see, my guess is we'll fall somewhere in between Australasia and the US. But, you know, it's just cultural, isn't it? I've got a bet on with somebody, you know, he's an American, he thinks nothing. Well, septic patients, give them 5 litres stat, they'll do okay. I go, It's philosophical, isn't it? It's just cultural. The other interesting thing, if I may, about ARISE and process that have been out, that why wasn't the Rivers data reproduced? I think because what happened in Rivers essentially was if you got randomised, you got Rivers looking after you. If you didn't, and you just got standard of care, which wasn't very good care. I think the advantage with the 2 multi-centre trials is that somebody was looking over them, a good research nurse or a doc, during that 6-hour period. Yeah. And there's some nice, I'll show tomorrow, there's some nice population data from the States where they looked at people who didn't get early goal-directed therapy. This is just population data, and there was a big difference in mortality. So I think perhaps it doesn't really matter what you do, provided you recognise a sick patient and do something for them, something appropriate and sensible. And we can argue about the trimmings, but the essence is recognition and intervention.
I'd echo that. I think the trials can't show some of the improvements that we see are by removing bad things that happen, and some of the bad things that happen are things that no one is going to do a trial on. So when I say, please give 20 of propofol and 20 mils of propofol gets given and the patient arrests, no one's going to do a trial of that. But if you're standing by the bedside, you can fix it. If you're not standing by the bedside, being Manny Rivers, and that 20 mils of propofol is given, that person becomes the statistic that's arrested that you highlighted in the paper.
Yeah.
I think the thing, though, I mean, that question about attention to detail, that's why the process trial chose to have the 3 arms, because they wanted to divorce out that question of is it the protocol or is it the attention to detail. And the mortality was no different.
Yeah, but they had a person there looking over the patient. Yeah. You know, so it wasn't that the standard of care people got ignored. They had the research nurse keeping an eye out.
Can I ask a question? I suppose, you know, after lunch we were told to be optimistic when wasn't Bob said he's very optimistic, but if I look at sepsis trials, it's hard to be very optimistic these days because everything that seems to have come through seems to be knocked down a few years later. And I can't see anything that I was, reading back in the 80s or the 90s that hadn't changed much in that period of time. But as you said, it's just the general care that's probably improved. So where do you think trials are going to go in the future? Are we going to do another randomised controlled trial of something? And if we do, how do we do it? And if not, what are we going to do? Databases or...?
I have the answer.
Okay.
Sorry.
Precision medicine. Yeah, I know. I think at the moment, and it's something I have lots of battles over pints of beer with Simon Finfer about this, and dare I say it, this is attacking the very heart of ANZICS trials research. The bigger trials are better. I think personally what we need to do is go personalised. One size cannot fit all, and so we've got to be a lot smarter. If you look, and again tomorrow in the sort of paper session, there's this sort of litany of, well, call them negative trials or neutral trials, where basically, good ideas either have been shown not to work or even cause harm. And so I think we need to look at the biology of the patient and try and titrate our treatment to the right patient at the right time with the right amount of drug and stop it at the right time. Just to assume that one patient should get 4 days of activated protein C for 4 days at the same dose, and that should be reproduced to everybody else, is crazy. Biologically, there's no rationale to it. And I think, hopefully, as a community, we need to realise that and become a lot smarter with trial design. That would be my plea.
Can I just pick up on one thing you said? I think we do have to get away from saying ARISE was a negative trial, Process was a negative trial. Any trial result is a positive result.
Yeah.
The result may be neutral, but I don't think we should continue to be calling trials negative. And I don't think we are the ANZICS negative trials group. I think we're the neutral trials group.
No, but by that I mean it was more a case of... Sorry. Yeah. It was more a case of many things have been tried with a reasonable biological rationale, but just applied wholesale across the board with no thought to, well, is this patient, an immunomodulating drug? Well, we don't actually know if they're immunoactivated at the time we give the drug. So it's crazy to give some immunosuppressant when the patient's already immunosuppressed. So I think, we just need to be smarter. And then if that comes out as a neutral trial, then so be it. It was a good idea but didn't work. But I think we just got to be a bit more savvy.
And it's also targeting, that whole area of pharmacogenomics, targeting drugs specifically to patients' individual genome.
To go back to your original question, you mentioned registries. I think in a way the registry approach does actually have some sort of value to the trials. Registries have been viewed as something different. I think ideally you'd have a system that monitored what was happening throughout your ICU, throughout your healthcare practice, and then instead of practice variation being random, and I'm not the first person that uses this phrase, this is very much a Ronaldoism, is instead of the random practice, you randomise the practice, and you have practice variation that you introduce as perturbations within the healthcare system, and then you measure those. And I think those are one of the ways forward for trials to measure what will essentially be small mortality differences and look beyond the mortality differences to outcomes that are more complex as well.
David, could I just pick up on one of the points that I think it was you who finished on, the point about us needing to go beyond mortality and be measuring a lot of other outcomes from our studies and from our care. Would you like to comment more on where we go with that? And how we do it in large scale?
Yeah, it's a good question. I mean, I don't think we've got very good measurements. I think we need measurements of functional outcomes and ways of not only measuring them at hospital discharge, measuring them further down the track. The measurements that do exist are relatively complex, and if we're going to measure things like that on a really big scale, you need to have very simple measurements that you can just collect through a variety of different means. I don't think we know what they are. I mean, you have the more complex things like SF36, EQ5Ds, all those sort of things. The frailty indices that people talk about, there are very simplified versions of them. It's an area that, you know, there's a lot of researchers looking at this at the moment. It'd be the kind of thing I'd love to see some very simple metrics that could be measured at a universal level across the healthcare system, from not only from ICU but from hospital discharge, from GP clinic type visits. Then you could look at really good long-term measures that go beyond mortality. But I don't know what they are yet, is the honest answer.
We're trying to do just that in the UK. There's now, with big data, you can link, and so what we're trying to do is link the ICUs with hospital outcomes, mortality statistics, GP data, so you see how often they have to come back to hospital in the next year, 2 years, whatever. Work and pensions, did they get back to work? Social security, and did they need a lot of social support? So you can, just by using data, actually address many of those points. So I totally agree with you.
The Canadians are actually looking at a similar study, looking at your taxable income after ICU, and using that as a functional marker.
If it goes up or down.
Yeah, I had just a comment, Manoj Saxena from Sydney, just about that thing. I think the thing that we should celebrate about the trials group and doing big trials is the fact that we can do them now, and that we, 10 or 15 years ago, it was just impossible to do studies on this scale. And the fantastic thing is that we now have the infrastructure. I think probably the direction to move off in is, as Mervyn and Dave have just indicated, is that we maybe need to look more carefully at how we select patients, and also this issue of the dwindling mortality and perhaps functional recovery becoming a more important issue. But the thing to celebrate about the trials groups, and whether they're neutral, negative or whatever, is the fact that we are here today and we do have that opportunity. Just a comment really, rather than a question.
Agreed.
There was a little mention before about pharmacogenomics, and what is it, $1,000 to get your genome sequenced? We're seeing lots of results coming through in the cancer sort of doing things, but do you think it is a way of the future? Are you seeing anything in your sepsis sort of reading in that, or is it going to be like the mediators and we'll target something that may sort of cause other problems that we don't entirely understand?
There's in the UK, there's active talk, because as you're saying, John, it's becoming cheap now. It's going to be even cheaper in 10, 15, 20 years' time. That every newborn child will have their genome measured or assessed or whatever. But obviously, that creates a whole load of ethical issues, insurance companies, etc., etc. But the argument is that if you've got the gene for cardiomyopathy or sudden death or whatever, wouldn't it be nice to know, or a cancer risk, etc.? It does open up other cans of worms, but I think the potential's vast, and it should be explored, but clearly the controls need to be exercised.
One example of the ethics is that if you look at salbutamol, for example, the response to salbutamol is entirely different between white Australians and Aboriginal Australians. So, for example, Aboriginal Australians don't have the same response to salbutamol that white Australians do. So salbutamol is on the PBS. So do you have the PBS just for those patients who actually responsive, depending on their racial group? So it's a big can of worms.
Done that with some medications for hypertension in the United States, haven't they?
Yeah.
For the African Americans, there are certain things that they can get on their equivalent of a PBS or subsidised because they know they will work.
There was a New England paper a few years ago with clopidogrel, and basically, depending on your cytochrome P450 polymorphism, it didn't work in some people and overworked in others.
It's crept into the transplantation world already. I mean, people are using genomics to assess rejection, and they use liver metabolism to determine whether you get azathioprine or mycophenolate. That's standard as part of picking your regimes for immunosuppression post-transplantation. So it's coming in one factor or one way or another.
I can't believe there's no points, thoughts.
Sorry, just because no one else was going to come to the microphone, I've come to annoy you again. There's an American entrepreneur called Jonathan Sakia, and he presented at a technology meeting in New Zealand in 2011 a very stunning and sobering statistic. And that was, he looked at the applications to boards for new technologies, and he listed it by specialty. So, and it's really asking the question, who's putting their hand up for new gadgets? And of course, we all know who they are. They're the orthopaedic surgeons, the cardiologists, the gastroenterologists. Well, where did intensive care come in that? In fact, we were so low, we were actually off the chart. You had to do a double line and way off the end, not even off the abscissa was intensive care. And you can think, do a thought experiment. Go back 30 years, Mervyn, you and I can do that, almost, and ask yourself, could I deliver the same intensive care with equipment that was 30 years old? And the answer is almost you could. We've got different dialysis, perhaps not so much, the ECMO isn't so flash, but I reckon we could. You ask that of any other specialty and they'd say absolutely not. Surgeons have got laparoscopes, oncologists have got better linear accelerators. So what I think is a problem with intensive care is the lack of investment into new medical devices and new ways of looking at things. And it comes back to your point, Mervyn, about personalised medicine. I mean, the ARISE study was using a practice that's been around for 50 years, and we don't know what we're doing. We continually don't know what we're doing because we're not trying to find out what we're doing. And I think that's the real challenge. And I just wondered if you'd like to comment on the lack of investment and the challenges ahead.
Yeah, I 100% agree. I think, unfortunately, and again, looking at our budget, I think from memory it was about 22% of our ICU budget goes on drugs and consumables. Virtually all of the rest is on staff. So we're very staff rich, but resource poor. So we have fancy machines that go beep, but as you say, they're just flashier iterations of what we had 20, 30 years ago. There's a big problem about implementation of technology. There is innovation happening, but it's the innovation being translated into the workplace isn't yet happening. It's not happening at a big enough rate. Again, I don't know what's happening in Australasia, but certainly in the UK, I think what the government are trying to do is trying to co-sponsor studies with, because essentially equipment companies don't have the resource of big pharma to do the studies you're talking about that would then propel them into standard use, because they're small companies without the R&D budgets to do the outcome studies. So I think there's support coming from, in the UK at least, relatively small, but it's happening, to try and let's look at repurposing drugs or new devices and see if that makes a difference, or diagnostics especially. There's a lot of work going on in diagnostics, but 100% agree.
Hello, my name's Aggie. I'm an intensive care nurse from Wollongong Hospital. I've never asked a question at a conference before, so please forgive me if my voice cracks. David, you very quickly touched on nursing ratios as being something that may influence how well patients do as a result of sepsis. And Sandy, you commented that a lot of your patients had to be admitted to ICU purely for the treatment that was prescribed to them for your study. Do you feel that they would have done as equally well if they were admitted to the ward bed that they were meant to have?
It's a bit hard to answer sort of something that didn't happen. I think that, well, put it this way, 70% of the usual care patients went to ICU, so there were 30% that didn't, and versus the 10% that didn't in the early gyratory therapy, and the mortality was the same. So on that, you would have to say that they probably did do as well.
And with the nursing ratios, there are lots of papers out there looking at nursing ratios. A lot of them are in the nursing literature rather than the medical literature. They're consistent in their association between better outcomes for the patient, doesn't matter what you look at, and having higher nursing ratios. They're not very high quality research as a general rule, and there are no randomised trials of it. But they are consistent across the board. There are very few pointing in the opposite direction. It is quite surprising when you go to visit other countries. The UK is relatively similar. My memory of ICU in the UK was 1-to-1 ratios, particularly for ventilated patients. I spent a few days in a French ICU this year where they had one nurse looking after 2 ECMO patients. So that was the opposite end of the nursing ratios spectrum. In the US, lower nursing ratios represent a different sort of model of care where the nurse coordinates other people coming in and providing the care. I think it's really difficult to say definitively that it's one of the contributors to our good outcomes. I think it probably is, but I'm biased, but I think it probably is.
I think my quick answer would be yes, they're great. There was a study done 20 odd years ago in Europe where essentially there were 4 from the north of UK ICUs who participated, and basically there was a very strong positive correlation between nurse-patient ratios and increasing mortality. And the reason was that the British units did the worst because we had the fewest beds. And so it's great to have the nurses, but you need to get the patients into those beds. And if you have to wait because they're rationed so much that you can't get a sick patient into a bed until they're really sick, then having a 1-to-1 nurse-patient ratio helps that patient, maybe. And that's the problem. You need the resource, not just the nurse-patient ratio, but the number of beds. You need more ICU nurses. That's my plea.
Yeah, and when you look within a single healthcare system, usually more nurses represent a higher severity of illness of the patient because you need more resources, of which the nurse is one of the main resources to look after that patient. Yeah. So it's difficult to tease out cause and effect from correlation.
Thank you.
And I guess that's part of that unexplained context that we really don't measure well in many of these studies. And we
Absolutely.
need to look at to work out what matters.
Well, it's sort of intuitively, we know what we'd like, wouldn't
Yes.
we?
Yeah.
You know, and it's like outreach. Intuitively, it must be a good thing where you've got somebody who knows what they're doing, seeing patients on the ward before they fall in a heap. You know, proving it's a different matter, but intuitively, you know, if I was a patient in a hospital, that's what I would want.
Yes.
A guardian angel looking over me.
We have for many years talked about an RCT in Australia where we randomise 1-to-2 and 1-to-1 nurses, and we know it will never happen, haven't we, Gabby? So, yeah, it's difficult to measure that sort of thing.
Yeah. And also the sort of quality metrics too, because again, in the UK, I think Australasia too, but you know, it's sort of restraints aren't used in the UK, physical restraints. They're happy to pharmacologically cosh them,
Yes.
but not physically restrained. Whereas when you go to mainland Europe, you know, they think it's normal. And again, there's been very little comparison of, you know, from the patient point of view. Well, did you like being sort of physically restrained or not? Exactly. Some may say yes.
Tied up.
Perhaps we shouldn't ask that question.
Seeing Sandy in a different light.
This is mainland Europe we're talking about.
Not going there.
Yeah, but, you know, in the UK, I presume the same in Australia, it's something, it's not, you know, the nurses, you know, are horrified. And they said, well, it's illegal. And I said, well, can you show me the law that says you can't do it? Well, there must be a law. And I said, well, cross the channel and you'll find it's common practice. In the US, it's common practice.
Yes. Yeah. I think, given everyone obviously wants a drink,
Including the speakers.
including the speakers, I think we might leave it there and